So good morning to all. We are starting our scientific session, and the first talk will be updates in type 1 diabetes by Dr. Anup Iqbal. So I invite Dr. Anup to make his presentation. Over to you, Anup.
Good morning, everyone. I'm very, very excited to be back in my alma mater, surrounded by all the faculty and mentors who have, helped me through my academic career. Again, this is still a dream come true, coming back to our very own beloved college. So I'd like to first extend my deepest gratitude to all the faculty members and mentors who have been very supportive throughout my academic journey. Your guidance, wisdom, and unwavering support have been instrumental in my growth. Today, I am honored to stand before you to talk about the recent advancements in type 1 diabetes mellitus in the pediatric population. Let's start off with kind of giving an overview of the current situation of type 1 diabetes mellitus in children. Based on the 2019 stats, we have close to 11 new patients with type 1 diabetes mellitus per 100,000 at the global level. And it's almost triple when we look at the age group 10 to 14. And at the global level, Europe kind of leads the number of children with type 1 diabetes mellitus, and the graph on the right side kind of shows that Finland kind of is a leading country among the European nations. If you look at the stats for India, you can see that around 100 to 130,000 children have type 1 diabetes in India, and the national incidence is very similar to the global incidence, around 11 kids per 100,000. Because the topic is about advancements in management of type 1 diabetes, I believe it's important to kind of go through briefly over the pathophysiology of type 1 diabetes. As we all know, type 1 is an autoimmune condition where there is rapid destruction of the beta cells of the pancreas that is responsible for production of the insulin. So with the destruction, what is going to happen is you will have elevated blood sugars and thereby with the diagnosis. This is actually a relatively newer concept of staging the process of type 1 diabetes. So you can see on the left side, and we also have genetic and environmental risk factors, but that alone will not trigger to initiate the beta cell destruction. So once that happens, then you have stage 1, where there is blood sugars remain in the bloodstream with destruction of the beta cells. And when you proceed to stage 2, there will be early signs of abnormal blood sugars and further progression of antibodies in the bloodstream. And in stage 3, that is where typically we have the diagnosis of diabetes mellitus, where the patient presents with the typical symptoms that we know of, namely the polyuria, polydipsia, polyphagia, weight loss, and excessive tiredness. And obviously, with this diagnosis, that is when we would initiate the insulin therapy. And stage 4 is long-term complication management. And by that time, we'll have significant loss of the beta cells. The traditional management involves multiple daily dose injection of insulin subcutaneously, and we would need to kind of check the blood sugars using a glucometer in order to see how effective our treatment is. It is associated, it's also, along with that, there should be focus on balanced diet, with specifically focusing on low glycemic index foods and also carbohydrate counting. And it should also be combined with exercise, and typically the recommendation around 60 minutes at least on a daily basis. Now let's go on to the actual topic of the presentation. That'll be the newer treatment options and the future of diabetes mellitus management. I'd like to start with talking about teplizumab. This is actually an anti-CD3 monoclonal antibody. So in order to explain how it works, we need to kind of look at this cartoon or the picture on the right side. So you can see that there are CD3 proteins that kind of adhere to the beta cells, and that is causing the rapid destruction of those beta cells. So teplizumab, how it works is it kind of clings onto those CD3 molecules and thereby reducing the rapid destruction of beta cells, and thereby delaying the onset of stage 3 type 1 diabetes. So based on the randomized clinical trials, what is shown is that the patients on the teplizumab treatment arm, there was delay of the onset of diabetes by close to 2 years. So think about it, 2 years of not having multiple injections daily and not requiring to do finger pokes multiple times a day. So that is what we are saving by initiating this treatment for the children who are at higher risk of type 1 diabetes mellitus. So namely, it would be those kids who are higher risk of developing type 1 would be siblings of children with type 1 diabetes mellitus, those who have already autoimmune conditions like Hashimoto's or celiac, and also they have the HR3, HLA, DR3, and DR4. So those are the individuals who could benefit from this because they are at higher risk of developing type 1 diabetes mellitus. It is currently FDA approved for children over the age of 8 years, and the way we administer it is an infusion, daily infusion for 14 days. And the side effects that we can expect with this treatment are you can have rashes, decreased white blood counts, headaches, nausea, and fatigue. And the serious ones, less commonly noticed, are cytokine release syndromes and increased risk of infections. So next is the same medication, but again, previously it was about prophylaxis, so delay the onset of diabetes. So this is actually looking at individuals who already developed diabetes, so the new onset type 1 diabetic patients, and the use of this medication. So for that, let's look at this graph on the right side. You can see the red line and the red arrow is where the treatment is initiated in children who have stage 3 or basically the diagnosis of type 1 diabetes mellitus. You can see that compared to those on the untreated arm, this is actually looking at the beta cell mass or the C-peptide levels. You can see that there is a significant preservation of beta cell function after initiating the treatment. So what was seen is when we try this treatment for new onset type 1 diabetic patients, those individuals who receive the treatment tend to maintain the C-peptide level longer. Their total daily dose insulin requirement was lower, with better insulin sensitivity and better glycemic control. So that is another use for this medication. Next, let's move on to another medication. Again, this is not commercially available. It's actually a phase 2 clinical trial. It's called baricitinib, and how it works is it's a JAK inhibitor. So what that means is, you can see on this slide, JAK inhibitor is when it's inhibited, or let's talk with what JAK does. So it actually produces, it's instrumental in the production of the inflammatory markers like IL-1 and IL-6 antibodies. And those are responsible for the destruction of the beta cells. So by inhibiting JAK, what's happening is you reduce these inflammatory markers, thereby preserving the beta cell destruction. This is actually compared to the previous teplizumab, which is an infusion, daily infusion for 2 weeks. This is actually a pill form, which is very good when we talk about treating pediatric patients. So this was actually in the trial, what they did is it's a pill that you take once a day for 48 weeks. And when they compared those children with, it's actually in the adult population, it's not extended in the pediatric population yet. So the adult data suggests that those who are on the treatment arm tend to maintain the C-peptide levels over the duration of 48 weeks. They required less insulin and better HbA1c control compared to those who were on the placebo. So this is actually something to keep an eye on. Once it's approved, it's going to be a really good option for the pediatric patients with regards to the teplizumab, which is an injection or an infusion. Next, let's switch over to monitoring blood sugars, and that is continuous glucose monitor. So typically, we would be using the glucometer to look at the capillary blood sugars. So what the CGM or continuous glucose monitor does, it's a device that's placed on the skin, and the probe or the sensor goes into the interstitial fluid. And it tracks the blood levels in the interstitial fluid, which is very similar to the capillary blood sugars. The good thing about this is you get a continuous blood sugar monitoring, which is tracked every minute to every 5 minutes throughout 24/7. So you would see the impact of your treatment, insulin, and also impact of food and activity on a real-time basis, which I think is going to help you significantly in overall management of diabetes. So these are the currently available various options for continuous glucose monitors. The range of wear is between 7 and 14 days. So you place the CGM and it works for 7 to 14 days. Continuously, you'll be getting those blood sugar readings. And none of them requires any calibration, so you're not expected to do glucometer checks or finger pokes while you're on this device. And the places that you place this device is pretty much all the places that you give your subcutaneous injections for insulin. And all of them are seamlessly integrated with smartphones. It can be uploaded to the cloud, or as we'll be talking in the subsequent slides, it seamlessly integrates with the insulin pumps. Let's move on to continuous subcutaneous insulin infusion, or commonly called insulin pumps. So in the 1920s is when we first discovered insulin, and the first insulin pump came up in 1960. You can see the picture on the left side. The first insulin pump was slightly larger than our typical backpack. That is how big it was. But fast forward now, on the right side, you see the Tandem Mobi, which is actually slightly larger than $0.25. So things have significantly advanced and progressed over this time frame, especially in the last 10 to 15 years. So things have been advanced, it's getting smaller and more efficient. So the purpose of insulin pump is to kind of mimic physiological insulin delivery, like what our pancreas would be doing. So you can deliver small units of rapid-acting insulin continuously, which is called a basal insulin, and then the user or the patient has the ability to give bolus insulin depending on the food that they eat. And there is high precision using insulin pump because the lowest insulin that we can give is 0.025 unit per hour. And you can program and customize how much insulin you get at different times of the day, which is very critical for children. And we can kind of mimic how their school routines are. Right? And as you can imagine, with this much of programmability and customizability, there is way more improvement in overall glycemic control and also limiting the episodes of severe hypoglycemia, which is always a nightmare for the parents. So the next is artificial pancreas. So what that means is a step ahead of, further from the typical insulin pump, where you have the continuous glucose monitor on one side of the body and the insulin pump on the other side. So continuously, those blood sugar readings from the CGM or continuous glucose monitor goes directly onto the pump, and using that information, the pump is automatically able to give insulin accordingly. So for example, if you see blood sugar is rising, those data comes from the CGM onto the pump, and the pump is able to automatically deliver higher dose of insulin to avoid those hyperglycemic episodes. And the opposite also is true. If we see that from the CGM, blood sugars are rapidly dropping, the pump can reduce or even completely stop insulin to avoid a severe hypoglycemic event. And that is called, the predictive low glucose suspend feature. And as you can imagine, with these more sophisticated algorithms and devices, overall the quality of life of the child and the family improves, and it reduces long-term complications because we are controlling those higher escalations of blood sugars and avoiding those hypoglycemic events. And it also overall reduces the burden of diabetes management. So these are the insulin pumps that are currently available. This is actually a summary of all those comparison of those pumps. And I'd like to just focus on the lower end of the chart, that's the unique features. So Tandem Mobi is currently the smallest insulin pump device that is tubed. And iLet by Bionic Pancreas, the good thing about it is you don't actually have to put in the exact carbohydrates. You just need to tell them, like, is it your typical meal, a higher carb meal, or a lower carb meal? And based on, that's all the information you need to put it in. And based on that, the pump is smart enough to figure out how much insulin you need to get. Omnipod 5 is the only tubeless currently available artificial pancreas or insulin pump that will help with blood sugar management. And if you can see the picture on the lower side, this is a young girl using the Omnipod patch. What it does is, because of not having the tube, so parents typically like it, especially for toddlers, because they don't have to get entangled with the tubing and whatnot and getting pulled or ripped apart. So Omnipod is favorable for toddlers, and that is typically what parents prefer. And lastly, the Medtronic 780G is a combination of all the previous features I mentioned, but it's another option. There are various meta-analysis and systematic reviews done comparing the typical multi-daily injection insulin regimen and also the insulin pump. And what we have seen is there is significantly more improvement in minimizing hypoglycemic events and also improving overall glycemic control. But the challenges that they found is, not unexpected, is the higher cost. And because there is no long-acting insulin and entire insulin regimen is through a small cannula from the pump, if there is any kink or any problem with the cannula, it can cause potential for ketoacidosis. There's another study looking at the 780G in 2 to 6 age group. I mean, not surprisingly, there is improvement A1C and time in range, which is fine. But I think the highlight is the parental stress. Over the time frame of 3 weeks, what has happened is there is a significant reduction in the parental stress in managing diabetes, which I think is important because parent stress directly impacts the child's health. So if there is anything that we can improve, that helps a lot. Okay. And then looking at the nutrition protocols, as I was saying earlier, unless you're on an iLet Bionic Pancreas, you have to be pretty good at your carbohydrate counting because that determines how much insulin you're giving through the pump. So if you're not very good at it, they're coming up with newer AI apps that you can install on your cell phone that actually takes pictures of your food and gives a fairly accurate estimate of the carbohydrates that you're consuming. So that is actually, in the development, and things are getting better day by day. Another one is treating low blood sugars. Traditional severe hypoglycemia is managed by an intramuscular glucagon. And again, as you can imagine, even healthcare providers, when our own child is having a seizure with hypoglycemia or unconscious, we may not have the mental will to give a shot at that time. But again, that has been replaced by an intranasal dry nasal powder, called Baqsimi. So it's similar to it helps with treating hypoglycemia, but it's a intranasal intervention. So it's easier to give. It can be used in unconscious patients, and it does not require any refrigeration. And finally, the pancreas or islet cell transplantation. It is mostly for adults right now and who have long-term had type 1 diabetes for more than 5 years or have other complications like unawareness of hypoglycemia or associated with cystic fibrosis. In 2023 June, we had the first approved islet cell therapy for type 1 diabetic for adults who have severe hypoglycemic unawareness. There were 30 patients who were in this trial. And what they found is 67% were insulin-free for the first 1 year, and 11 patients remained insulin-free for 1 to 5 years of years, and 10 remained insulin-free close to 5 years. And they were well controlled in their blood sugars and had very minimal hypoglycemia. It does have its own complications, like liver laceration, hemorrhage, and hematoma, and serious infections. I mean, this is actually just the beginning. Things are only going to get better over time. But the main thing is, we talked about a lot of strategies to help improve the glycemic control of the patient. But I think the key factor is the comprehensive care approach of the multidisciplinary team that should involve an endocrinologist, diabetes educator, nutritionist, a physical therapist behavioral specialist, school nurse, and a social worker. The school nurse and the social worker would be our liaison from the clinic to the school and home, which is critical in managing these children with type 1 diabetes.
Stopping?
Yeah. So I'll just stop by saying that, things are pretty bright in managing type 1 diabetes, and I'm very excited that it's going to be better. And, it's really going to be a nice future for type 1 diabetes with all the technologies and the development. Thank you.
Can we have a small discussion now? Right?
Whichever, yeah.
Yeah, as an ophthalmologist, I'm very much involved in this. So, discussion towards the end of the session, of course. Sure.
Sir, can we hold on the discussion to the end of the session?
Let the talks go on.
Okay. Thank you, Anup. Now we are moving on to the next session, that is USS guided blocks for regional anesthesia by Dr. Dheeraj Kamalam. Dr. Dheeraj, over to you. Thank you.
എലിസബത്ത് വരുന്നു ഇവിടെ ഫസ്റ്റ് സെഷനിൽ ഇയാളെ കണ്ടില്ല, അതുകൊണ്ടാണ് ഞാൻ ഇരുന്നത്. ഓ ഞാൻ എന്നാണ് അറിയിച്ചല്ലേ, അതാണ്.
Hello everyone. This is my classmate, my next number in 82 to 87 batch. Dheeraj and myself have sat together for all the anatomy, physiology, biochemistry, everything. And I'm so pleased that I'm standing here, just got in this morning. Dheeraj was with us for the 82 to 87 UK group of us who were having a get together last week. He flew from Manchester to Peak District, and he was with us for a couple of days. And I'm so happy that this morning I've reached and I'm able to not introduce Dheeraj, but just talk about or being here alongside him. So thank you very much, Dheeraj. Thank you.
Good morning, everyone. It is my distinct pleasure to be here in the alma mater, in an auditorium where we had so many nostalgic memories created in the forms of youth festivals and college events, and we sat for examinations right here. And now, because of the Alumni Association, under the leadership of Dr. John Panikkar, it has been transformed into a space we can have such beautiful events. And everybody who worked behind this, it deserves kudos. So, my topic is ultrasound-guided peripheral nerve blocks. Nowadays, there are people are being on anticoagulation for various reasons, for stroke prevention, for after coronary artery stenting. So there is a chance of neuraxial hematoma with the traditional techniques of neuraxial anesthesia like epidurals and spinals. But the use of ultrasound-guided peripheral nerve blocks gives us the ability to target these areas that generate pain for surgeries specifically. So it is very safe because it is done under vision with a Doppler ultrasound, and we can see the blood vessels and the nerves very clearly, and we can target the delivery of the anesthetic as needed. Also, that is the reason why this has become a part of the ERAS protocols, the enhanced recovery after surgery, because we can ambulate the patient early. Especially in the Western world, there's a push of the insurance companies to bring the patient out of the hospital as early as possible. So these anesthetic techniques will help to achieve that goal. The ultrasound machines have multiple manufacturers, but basically we have the probes this is the linear high-frequency probe that we use for most of the blocks. And this is the curvilinear probe that has a wider angle of vision, and we use especially for spine blocks, erector spinae blocks for spine surgery. Obviously, we use the sterile techniques, and we lightly sedate the patient. We have a conversation with the patient because accidental local anesthetic toxicity we had to detect early. The needles that we use are short bevel needles that cause minimal injury to the structures, and also they're echogenic, so they throw a better shadow under ultrasound. I can visualize better, and they come in different lengths, depending on the side of the block and the general body habitus of the patient, we can use a 50 millimeter or 90 millimeter needles for that. So that one, so we ergonomically position the patient. Usually the block side, the anesthesiologist is standing on the block side, and the machine is on the opposite side, because most of the blocks are lateral to medial. The bread and butter, for upper arm surgery, the supraclavicular block can be used as a primary anesthetic or as an adjuvant to general anesthesia. When you put the transducer on the supraclavicular fossa transversely, this is the picture that you see. You see the subclavian artery, the pulsating subclavian artery, and to the side of it, you have a honeycombed appearance. This is the brachial plexus. And usually, and you can, advantage of the ultrasound is you can see the pleura as a transverse hyperechoic line, and you can see the shadow of the first rib. So this is the no-fly zone beyond which the needle tip should never go. So we try to target you'll see the next slide. We are trying to target this is the plexus, and the needle comes from laterally, and we are trying to get to the inferolateral pocket. So this is subclavian artery. This is the area we want to target first, because this is the lower trunk of the brachial plexus. We go in there, you get that pop when you go into the facial sheath, and then you inject the anesthetic. You can see the nerve root spread out and become more prominent as the anesthetic proceeds. We can retarget the needle into the upper two trunks later on. The interscalene block is very useful for shoulder surgeries, total shoulder replacements, rotator cuff repairs. Basically, we start off at the same supraclavicular fossa, and we move the transducer up the neck, and you can see the nerve roots line up like a stoplight or a traffic light, or there they call it the snowman appearance. So it is called interscalene because it is between the anterior scalene and the middle scalene muscles, which appear as hypoechoic or darker areas, and in the middle you see the interscalene groove with the brachial plexus roots. So the color Doppler is very useful in the neck because the nerves in the neck appear hypoechoic or darker, just like the blood vessels. So the use of color Doppler is very useful. You can see this is the live video. You can see the nerve roots lined up like a stoplight sign or a traffic light sign. This is the anterior scalene and the middle scalene. You will see the needle coming in from here, lateral to medial, because that approach is better for avoiding phrenic nerve injury. So initially we target in the upper between C5 and C6. Either you can pop into the fascia and give it there, or you can find a space, you can go between the nerve root and go to the opposite side and start injecting from that side. The femoral nerve block is widely used for neck of the femur surgeries, hip surgeries, knee surgeries. It is a sensory and motor block. So when you put the transducer on the inguinal crease transversely, you can see the first pulsating femoral artery, the femoral vein which is compressible on the more medially, and this triangular structure that you see is the femoral nerve. The important thing to note that it is between two layers of fascia called the fascia iliaca. So unless you get that tactile pop into the fascia iliaca, your femoral nerve blocks are not successful because you have to give it under the fascia iliaca. So you see the injection, you can see the needle coming in from here, and first they give small incremental 1 cc injections, and then the target actually is right, here, lateral to the artery. This is the nerve which is the target. But this needle will be redirected towards here, and once the injection proceeds, you can see the local anesthetic spreading around the nerve, and you can see the nerves better delineated. And every time before you inject, you have the assistant aspirating and checking at whether you are backflow of blood, because that is very important in avoidance of local anesthetic toxicity. The fascia iliaca blocks have been developed because it has less motor. The femoral nerve is motor and sensory, but the fascia iliaca blocks are more sensory. So the fascia iliaca, it is the same, you start off same, and yeah. And then we move the transducer laterally. You can see this fascia iliaca is the fascia that is covering the sartorius muscle. And that fascia is usually approached from lateral to medial, and the target is around here. And once you get that pop, and when you inject the medication, you can see the facial unzippering. They call it unzippering of the facial plane. And some of the anesthetic will migrate towards the femoral nerve, and some of the anesthetic will migrate towards the lateral femoral cutaneous nerve of the thigh. So you get a very good analgesia. The advantage is you can do it pre-op when somebody is, especially elderly patients in the emergency room. We can do a fascia iliaca block. You can do it in like less than 5 minutes, and you have very good preoperative analgesia. Intraoperatively, we use very less anesthetic, minimize the narcotic usage, and post-op also it is good. Early ambulation, usually when they do a total hip, they ambulate the patient within hours of surgery, so it is very useful for that. As the popliteal block is widely used for foot and ankle surgery, so the sciatic nerve going down close to the popliteal fossa, it becomes a popliteal nerve. And just like half an inch or like 1.5 inches above the popliteal crease, it branches into tibial nerve and the common peroneal nerve. So at that point, it is enclosed by a common fascia called the Broca sheath. And so if you give the anesthetic right there in the middle, you get both the nerve roots and we get a very good distal block. You can see this is the common tibial nerve and the common peroneal. So he's trying to go on that side. So then we withdraw the needle and give it in the middle. You have a very good local anesthetic spread around both the nerve roots, and there is an excellent block for foot and ankle surgery. The IPAC block, otherwise called the interface between the popliteal artery and the capsule of the knee block, was developed because a lot of people with total knee replacements are known to have posterior knee pain. So this is a block that is used to target the area between you see the pulsation, this is the femoral artery pulsation, and then this is the capsule of the knee over the femoral condyles. So the needle is coming from here, and it goes in between the femoral artery, the popliteal artery and the capsule of the knee, and the anesthetize the terminal branches of the geniculate nerves and the popliteal nerve. So that is very useful for posterior knee pain after knee replacements. The TAB block is a really good block for abdominal wall surgeries of any kind, laparotomies, hysterectomies. The abdominal wall has 3 different planes: the external oblique muscle, internal oblique muscle, and the transverse abdominis muscle. So these 3 are separated by facial planes. So the TAB plane is the plane between the internal oblique and the transverse. So this plane is targeted. You can pop into that plane and give the local anesthetic. You can see it very well. It's very rewarding block. You can see. So this is the subcutaneous tissue. This is the external oblique, internal oblique, and transverses. And this is the TAB plane. So you can see the needle approaching, and then you come in from lateral to medial. You pop into the TAB plane. You can see and feel the pop, and then you inject the medication. You can see the unzippering of the TAB plane, and the needle. You keep on advancing the needle from the anterior axillary line all the way to the mid-axillary line. So you get the anterior and lateral cutaneous branches of the intercostal nerves and the thoracodorsal nerves. So you do this block bilaterally. You get very good analgesia. You don't have to use narcotics in the postoperative period, leading to bowel ileus and all the problems that happen with that. The rectus sheath block is for midline surgeries like ventral hernias and umbilical hernias. The rectus in the middle, you see this is the rectus muscle. You target the posterior rectus sheath, and you give it just above the posterior rectus sheath. It raises the rectus abdominis muscle up. So you can see the anesthetic being delivered. This is the posterior rectus sheath. Below that is the peritoneum. So you give it right at the posterior rectus sheath. It will lift the rectus abdominis muscle up, and you do it bilaterally. It's very good for ventral hernias and umbilical hernias. The PEC 1 and PEC 2 blocks are for mastectomies and for axillary dissection, and also for breast implants and all that. The PEC 1 block targets the pectoralis, is between the pectoralis major and pectoralis minor, this facial plane, and the PEC 2 block goes in the plane between the pectoralis minor and serratus anterior. So you can see the transducer will show you the rib, it will show you the pleura. Below that is the pleura, and so you can see very well where you're giving it. You can see this is the pectoralis major, this is the pectoralis minor. You will see the needle coming from here, and you're targeting this facial plane. You go in and you feel the pop into the facial plane. You inject, you see the facial plane opening up. It is called unzippering of the facial plane, and the anesthetic goes in there. And this is the third rib, and the shallow cast of the third rib. And then you advance the transducer further down. You can see the fourth rib, and at that point, the differentiation between the pectoralis minor and serratus anterior is very obvious. And so this is the facial plane we are targeting. You pop into that facial plane, and you give it, and you can see the spread of the anesthetic. It is so definite that it is in that facial plane. So this is very useful for mastectomies and, okay. This is the erector spinae block, and it is for spine surgeries. Nowadays, they're doing a lot of spine surgeries. And the erector spinae block, you can do it in sitting, lateral or prone position. We usually do it after we intubate the patient. We turn the patient over. Before they do the surgical prep, we can do it. So the transducer is placed vertically. This is the curvilinear transducer. And your aim is to target the transverse process and you raise the erector spinae up. So you will see the injection proceeding. So the needle you will see is coming from superiorly or inferiorly. So you can do either way. And you see the target is, this is the transverse process and the tip of the transverse process. And when you inject, you can see the erector spinae muscle being lifted up. The advantage of this block is, when you do this, it spreads 2 levels up and 2 levels down. So for thoracic spine surgeries, we can do it in T5, and lumbar spine surgeries, we can do it in L3, and it gives a very good anesthetic spread. And we start off the transducer laterally, the ribs are circular, and then you come medially, you see the square transverse process, and you give it at the lateral border. No discussion about local anesthetic injections are complete without the mentioning the local anesthetic systemic toxicity or LAST. This is a real thing. It happens rarely because we take a lot of precautions like keeping the patient lightly sedated, monitored. We have a conversation with the patient, and we should detect it early. So the treatment for that is 20% intralipid. That is the same thing we use for TPN, total parenteral nutrition. 20% intralipid, it should be available in every block card. You give 100 ml of that infusion, and that's the treatment. The problem is that local anesthetic binds to the sodium channels of the heart and causes a cardiac arrest. So we treat early, that doesn't happen. This will bind the local anesthetic. So this has to be part of every block card. So that's my hospital, HCA Aventura. Thank you very much for having me over and giving me this opportunity to be with all of you. We had so many relationships renewed, and it is such a blessing. And thanks to the scientific committee, Dr. Vinay Kumar, Kavita, Ravi, Lakshmi, Dr. Suma, all the people who work behind this. This is a tremendous conference and enjoying every minute of it. And so glad and blessed to be here. Thank you. And enjoy the rest of your day.
Thank you, Dr. Dheeraj Kamalam, for the excellent presentation and the nice words. Initially, when I started, I inadvertently skipped or missed the session by Dr. Deepu Sudhakaran, the president of ATMG. But later I understood that there is a noble cause. And I believe that there's nothing casual and everything is causal. Now over to you, Dr. Deepu Sudhakaran, for your presentation. Thank you.
Can I control it? Good morning, everybody. You know, it's with great pleasure I stand here in my alma mater, and it's been a privilege for us to be here because, you know, as everybody said, we have been here, did multiple exams here, and a lot of friends we have made. And thanks to all the Dr. John Panikkar and the team who has invited us. And initially, I thought, you know, we all from the United States wanted to come down here and do the presentation, and we are here, and we enjoy our time here. So, with that, I was supposed to be. I was not MIA. I was here, but my parents wanted to see my presentation, so I requested Anup to go first, and thank you, Anup, for that, and Dheeraj to follow. And I'll go into my presentation. I have few slides. I'll try to stop it in time. Okay, I might skip through a few slides very fast. So this is what I did in the United States, and I have no disclosures. So I'm going to talk about obesity. So, and this is a hot topic for all of you know that. And there are, you know, it is defined by weight by height square, and there are multiple levels of obesity. I'm going to be talking mostly in the United States terms. So please forgive if I don't have any data from India. So. And here you can see how bad the United States is having with obesity. And you can see it is only 2010, and Southeast United States is like over and above 68% is obese in the United States. And here you go to cost of obesity. This is like a very busy slide and has a lot of causes. You might just think that, oh, he's eating too much, so that's why he's obese, which is not very true. There is a lot of factors and causes for obesity, and we have to, most of the time we have seen that doctors are the people who have a bias and don't want to see obese patients, and so that's something we have to overcome to treat obesity. We should have a good discourse with the patients about obesity. So what causes obesity? There are some highlights which I'm going to show. You know, you used to have a cup, small cup tea. Now we have a big cup tea. And then we have 20 years French fries like that, sandwiches, big, and the lifestyle has changed too. So, and you might think, why I'm going to the gym but I'm not losing weight? So here you can see 500 calories in 50 minutes when you go walk, but you give back that 500 calories in 5 minutes if you take a bagel. So you cannot get a negative balance of energy to lose weight, and it's primarily from eating. So that's where we have to focus on diet control and activities. So this is a pandemic, and you can see this is a landmark study which showed that the obesity, as the BMI goes up, the chance of cancers, different type of cancers are rising. And here you can see the diabetes, which is increasing as obesity goes up. So what's the treatment for obesity? You can see this pyramid. Surgery is very top, then endoscopy, pharmacotherapy, and lifestyle therapy. So you see a pyramid like this, and you can see that there are, in the bottom, it's more exercise and healthy food, and way at the top, you can see it's more carbohydrate rich food. And you can see one thing which is clear there is a fish there right in the middle, so it's a good protein. So what are the different options? So we talked about the conventional methods, medical therapy, endoscopic methods. I'm going to touch through all of these quickly. Medical weight loss therapies, we have a very comprehensive weight loss management process, which include dietitians, exercise coaching, behavioral modification by the psychologist, and obesity medications based on given by the doctors. And these are the list of medications we have in the United States. I'm not sure what all we have here, but phentermine is time tested, been used for quite a long time. We start with the low dose, go up, and then topimate and bupropion also is used, and you can see it is also used for smoking cessations and interaction. It has an interaction with MOA, so you have to be careful about that. Combination therapies like phentermine, Topomax combinations, and bupropion, naltrexone combinations are used. And bupropion, naltrexone is used usually for patients who have some kind of a sugar addiction or some kind of psychological induced obesity. Here you can see diabetic medications which are also used for obesity management, and they are metformin, and you can see SGL2 inhibitors, liraglutide, semaglutide, and tripizide. So you probably might have heard about Ozempic and Mounjaro and the drugs which are newer drugs with GLP-1s and GIP-1s. It's way much used now. In fact, it's used very unregulated, even in the United States, truly, and so some resistance is happening in that level. So it can bring about 20% weight loss, so definitely those are really good drugs, but it has to be combined with other forms of interventions, not just the medications, which is what it's going to create a problem. As we started using antibiotics, we had antibiotic resistance. These medications are slowly getting that problem. There are some volume expanders. When you take in, it kind of fills up your stomach. You don't feel that hungry, so that's there. And then newer medications, you can see those ones. So it's a great time for medications, and there's a lot of medications coming in. I think it's going to change the spectrum of how we treat obesity in the United States. So moving on to endoscopic weight loss, you can see the first three remains the same. Then you go to gastric balloons and endoscopic sleeves. So gastric balloons, you can see basically it's putting a 500 cc's gastric balloon in there, and it will fill up the space, and you will feel not so hungry. And FDA has only allowed it for 6 months. We usually use for big, very huge patients to get some weight loss before we take to surgery. So that's one process we do. Some people, like, for I have a marriage to attend or something, I want to lose like 20, 30 pounds, I'm going to get a balloon, just lose some weight, and then we have to take it out. So it's a very costly procedure, $7,000 procedure, which don't want to, and it's only used for temporary purposes. Endoscopic sleeve, which is decreasing the cavity size of the stomach from inside. It's it's an outpatient procedure, so it can be done, and you can see how the cavity size is decreased. And this has a little risk in by trying to, if you don't know where you're tying up, and you can get the spleen or splenic artery or pancreas if your needle goes a little outside. Surgical options: sleeve gastrectomy, Roux-en-Y gastric bypass. I'm trying to look at the time in between to make sure I don't overshoot. So sleeve gastrectomy is restrictive. You can see, and Roux-en-Y gastric bypass. I'm going to go show how it's being done as well. So this is a very significant slide. It says it's resolved, not getting better. Okay, so you can see diabetes is resolved 95% of the time. Hypertension 92% of the time. Obviously, cardiac functions can only be improved, and so that's the significance of bariatric surgery. And even the GLP-1s are showing this kind of advantage these days, not to the extent that surgery had. So here you can see this slide which shows that surgery is, it is a little more expensive, but it flattens out. So that's why United States, every insurance companies are accepting bariatric surgery, but the cost of medications and all is going so high. So it's definitely a cost-driven and very effective treatment. That's why bariatric surgery is, we are using bariatric surgery there. And it pays off for 3.5 years. So indications for bariatric surgery: BMI greater than 40, or BMI between 35 and 40 with a few comorbid conditions. And some exclusion criteria like pineal disease and stuff like that, which we check. This is the first prototype was done in 1967, and I will show a little bit of a video of that.
To gain access to the abdominal cavity, Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. The upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body,
Okay, so advantages, greatest impact on comorbid conditions, especially diabetes, relatively rapid weight loss, greater sustained weight loss. Some disadvantages are there, especially you can see marginal ulcers for smokers and NSAID use, some internal hernia issues. Sleeve gastrectomy, again, 80% of the stomach is removed. Here I'm going to show you how it's done. I want to really...
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is mixed with digestive enzymes to help break down the food to a more simple form, so that it can be more easily digested and absorbed when it is in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed.
So advantages, it's almost comparable with gastric bypass. Weight loss is pretty much the same, but it has a little less impact on diabetes. No anastomosis, marginal ulcers are very rare. It can be done within 30 minutes. So very quickly can be done. Very, very sick patients with CHFs and mitral valve stenosis and all can be done. So we do it. And some aggravation of reflux disease are the issues. Here you can see surgical complications, ulcers, anastomotic leaks, staple line leaks. They're very, I usually tell, we are safer to get a bariatric surgery in the United States than flying in an airplane. So that's how much you can see how the comparison is. Some side effects which you can get, hair loss is something which people talk about. It's a physiological response of losing weight. And then you can different options of which operations. Roadmap, we do some testings before we take the patient to surgery, and something called support group meetings, dietitians, all these testings are done. We go to surgery. Post-operative, you have to understand that patients can only take about 2 to 4 ounces per hour. So that's the main thing you will see as a big difference, is that you'll be eating small quantities. Liquid diet, pureed diet, low-calorie diet, increasing proteins. It's a step-by-step process. It takes about 1 month to get you to kind of normal diet. Things you should avoid is smoking, follow strict diet. There's a very strict follow-up here, and you can see, and it's a combination of all these things: nutritional resources, surgery, communication, community outreach, education, behavioral modification, support groups, and shared decision with the patient. So to be to have a successful any type of bariatric weight loss program, you need to have all these components. And if you just do surgery, you will say, oh, ellam kanjittu weight ellam koodi ennu parayum. So it's just that you need to change the behavioral modifications, and that's the main factor. That's it. Questions? That's the hospital which I work.
Thank you, Dr. Deepu Sugadaran. Can you please wait there for the discussion for the question and answer session? Now we'll, that's it. Move on to the last topic on this session. That is pulmonary embolism, advances in mechanical thrombectomy by Dr. Najib Usman. Over to you.
Good morning, everybody. It is such a privilege to be here among my dear teachers, friends. It's always a nostalgic feeling to be coming back here. I thank all the organizers, John Panikar sir, Vinay Kumar sir, so ma'am, Dr. Kavita Ravi, and all the organizers to give me this privilege to be among you again. So we'll just talk about the silent killer who hides in plain sight among us. In our leg veins, in our pelvic veins, he hides and ready to strike any time. Any clinician would have missed it. All of us, all experienced, inexperienced, the patient with the PE will be walking in front of us, we would have missed it. And nobody is exempt from that. So it's a very huge problem. About 100,000 deaths every year by CDC data. National Academy of Medical Sciences in India also gives a DVT prevalence of about 1.8%, one-third of them may be having PE. So it's a huge problem. So the mortality in low risk is very, very low. It's less than 1%. And in intermediate or submassive, basically how we say submassive, dilatation of the right ventricle and plus minus biomarker elevation when the hemodynamics are well preserved. And high risk or massive, and that of course is mortality 6 to 8%. And in high risk, of course, it is close to 1/3. And 5 to 10% of all in-hospital deaths are actually caused by pulmonary embolism, or at least majorly contributed by it. So it's a huge issue. And this is, the namesake of Vinay Kumar sir. It is the pathologist, Dr. Vinay Kumar, Robinson Vinay Kumar. The triad of thrombosis, embolism, and infarction are like the proverbial vultures who hover around those who are least able to withstand the attack, and they kill them usually. So how do we diagnose it? This you all know. Anybody would diagnose at this time. You will see a Q wave in lead 3 with the T inversion, and an S1 in lead 1, S1 Q3 T3 pattern, very specific, but we hardly ever see that. So hardly 10% of patients with pulmonary embolism will have that, and commonest finding is just sinus tachycardia. The gold standard now is actually, everybody knows it is a CT pulmonary embolism. That's what we do all the time. The treatment is very simple. Just anticoagulation. You can use anything you want. You can thrombolize the patient. That is very important. Now the change is here, whether it is intravenous or whether it is catheter directed. And last but not least is the thrombectomy, whether it is percutaneous, large bore, or surgical. So I'll just talk about 2-3 patients, all in the 50s. One who had a cabbage, a thin guy coming with 2 days of a dizziness. The other gentleman who had a classic situation, obese, multiple risk factors, just had a internal fixation of an ankle fracture, goes to McDonald's and eats a Mac and feels dizzy, comes back to the ER straight away. The last one is a patient with a Lysinople-induced angioedema. And he is in shock. There is nothing else is there. People don't know what's going on. So what do they have in common? It's a wonderful team, taking care of them to save their lives. So we'll just see what this, okay, good. So this is the serpent that we are seeing in a POCUS ultrasound. Basically what we are seeing is moving around clot within the heart. So you can see that it's not a baby, but it is just moving clot within the right atrium you are seeing. So, okay, good. So this is the CTP. You can see just a strand of saddle P in the pulmonary artery as well. You can see a grossly dilated right ventricle, right up top on white. So it is submassive. And this is a different thing. This is the thrombus in transit, TIT. It's not always funny thing. So it can cause mortality up to 80 to 100%, depending upon what situation the patient is in. This has been diagnosed and recognized for a long time, right ventricular thrombus masses. And without treatment, the mortality approaches 100%. This is an old study from 1960 to 2000, and the recent from our colleagues from Case Western. Similar data of 3 main treatments that we talked about, that is heparin, surgery, or thrombolysis those times. You can see that just anticoagulation alone causes mortality of 30%. No treatment, it is 100%. Heparin alone, it is almost 30%, and surgery a little better. Thrombolysis actually is much better, almost 10 to 11%. And you can see that in a multivariate logistic regression analysis, the most important thing that really saved the lives of these patients are thrombolysis in that era. This is up to 2015. And this is the PESI score. I won't bore you with the PESI score. You can calculate, but more importantly, clinical pointers that I told you in the beginning is more important. So these low, intermediate, and high risk, it's a dynamic continuum in a given patient it could be. So whenever clinical deterioration occurs, either by dropping blood pressure, raising heart rate, drop in saturation, actually we are in trouble. So we may have to think the strategy, we have to change the strategy what we have been doing initially. So as you increase the risk of pulmonary embolism, actually most of these patients have increased bleeding risk also, which cause a problem for treating with regular anticoagulation. So this is the life of cardiologists these days, multiple pages. There is a STEMI team, there is a shock call, and there is an ECPR, and now the PERT also, pulmonary embolism response team. Pages keep on coming, actually, but it is fun. It is saving lives. That's a good thing. So all the catheter-directed era started with this trial, the Seattle 2 trial. This was a single-arm catheter-directed thrombolysis in submassive and massive pulmonary embolism. So this catheter goes through a 6-front sheath. It is called ECOS catheter. This is an ultrasound catheter which has got ultrasound seeds. You can see that dark spots are all ultrasound seeds, which is put either through the jugular or through the femoral vein through a sheath, and it is kept in both pulmonary arteries. So this ultrasound will vibrate and desiccate the thrombus, and through the same sheath you will be infusing TPA at a lower dose than the regular TPA that we give for massive pulmonary embolism, which is 50 to 100 milligram. High incidence of bleeding problems. But here you are giving just 1 milligram per hour, and it is given continuously for almost 12 hours you give, or just 24 milligram only given, that too at an extended period of time, so it is pretty safe. So in this study, they looked into the classic patient with RV to LV ratio more than 0.9, and either with the biomarker elevation, and they gave TPA in this fashion, and found that the surrogate endpoints of reduction in RV size in 48 hours was significantly less, with very, very minimal side effects, even though it did have some bleeding problems, up to 10%, nothing major, no intracranial bleed as well. That's the most important thing. Then came the mechanical thrombectomy. That is actually later kit in the block, and this is called the Indigo Penumbra aspiration system. This is a 12 French sheath, and one French is 0.3 millimeters. So 12 French is almost 3 to 4 millimeter size aspiration catheter, bigger size. You can remove very efficiently much of the clot. Similar kind of patients with submassive were enrolled in this. And this also showed that significant reduction in RV-LV ratio. did have some safety concern, including one death related to catheter sucking into the pulmonary artery and causing damage. Now they have come with another software called Flash. As soon as it sucks the clot, the force of suction will come down, so that it will take the clot and then it won't suck the wall too much. Before this itself, 2016-17, this study was conducted with the INRE floater, a much bigger sheath, 24 French. And this you can also see that there is a disc at the tip which we can use to loosen the clot and then extirpate the clot much better. This is what we use most of the time, even though we have Penumbra system. Penumbra is available, much smaller catheter for the coronary, but this one is very efficient suction. This company was just last month taken over by the major peripheral vascular people, Stryker. So this FLAIR study, which actually was published in 2019, towards the end of 2019, where INRE catheter was shown to be very effective and safe, led to the FDA approval of INRE catheter for large bore thrombectomy. That's the first one to be approved in early 2020. And then came more studies about clot in transit, because the only approved treatment for clot in transit before that was actually mechanically, it's only surgical embolectomy was the one that was approved. Only you could give thrombolysis only if the patient is not a suitable candidate for surgical embolectomy. You can see that how bad that would be. So these case reports and other case reports led the FDA to give clearance for INRE medicals for using INRE catheter for clot in transit, which is a very dangerous condition. So this is one of our patients. You can see one catheter, that is INRE catheter. You can see the size of the catheter. There is a wire going through that, and there is a thin structure that you are seeing by the side of it, and that is the ICE, intracardiac ultrasound. So you can see what it is like. You can take a peekaboo there. You can see the clot is looking at you in between. So this is actually not babies again. These are just the clot and the wire inside the right atrium, almost 100% fatal if you don't suck them out. This is actually the clot getting sucked onto the catheter. It's not moving anymore. And you suck it out. Sometimes it won't completely come inside. It'll completely be blocked. So you have to slowly pull the catheter down. You can see the outline of the clot actually at the tip of the catheter. You can see that. And when you have such a thing, you have to take the whole catheter out, slowly pull it out of the body, only leaving the wire inside. And once you pull it out, this is what you see. And don't think it is just a lollipop. That is what it's called. It's called lollipop. So you take it out and then go back in and suck more. So these kind of clots that you will get. And you can see that, that filling defect in the pulmonary artery. Now, you can sometimes, it's a little bit older clots. You may have to deploy those discs distal to the catheter, and then deploy those discs. That will actually mechanically disrupt the clot, then you will be able to pull back. So these devices get you fantastic results like this. We have published this results also. There is a similar, the last one was the lisinopril induced we thought that is angioedema, and troponin was elevated. They insisted the pulmonary critical said you should have to shoot the course. Obviously, it was negative. This cannula is not the INRE, it is actually ECMO. I did this on the ECMO, and then I wanted to use a right heart cath and see what's going on. And this is what the right heart cath showed. Both pulmonary arteries were completely blocked by clot, and we used the INRE catheter to suck out those clots also. And then we got that patient also out completely. So very gratifying procedure. At the end of it, pulmonary arteries are all clear, and you get the fantastic, you can see the hemodynamic changes that happens very well. So, from the beginning pressure of about mean pressure of 35, PA pressure come to 18, and the PA saturation improves 53, and, it's a wonderful result that you have. You can see it on the table itself, you can see that. The LV function of that patient actually improved after pulmonary thrombectomy. This can be used for other things also. Big vegetation on the tricuspid valve, especially with the drug-induced endocarditis, large vegetation, you can suck it out using that. This is from our group, actually, this paper also. And sometimes you will need the surgeon. no question about it. This is not clot. This is the chronic clot, the chronic thromboembolic pulmonary hypertension. Actually it will go into the, you have to open up the pulmonary arteries and tease it out, pulmonary thromboendarterectomy. So there are multitude of trials in the PE. The most important that we have, this is HI-PEITHO trial comparing catheter-directed thrombolysis with the conventional therapy. It is not completed. But PEERLESS trial is the first randomized control trial comparing catheter-directed thrombolysis with large bore thrombectomy. It clearly, the large bore thrombectomy came as a winner. No question about it. So what is new? It showed that randomized control trial to compare these two strategies, and large bore thrombectomy is associated with significantly lower rate of clinical deterioration and escalation to bailout situations. So, intermediate, so this should be the initial approach if you have significant dilatation of the RV or biomarker elevation. So that is the role of large bore thrombectomy at this time. So if it is a very high risk patient in shock, you can still give IV thrombolytics full, but otherwise, you should always give a consideration for large bore thrombectomy. So it is rapidly evolving phase. PEERLESS has established the role of large bore thrombectomy in submassive PE very clearly, and this pulmonary embolism response team is very, very important. It's a multidisciplinary approach, and now more and more studies are in the pipeline. These are our fellows, and it's a wonderful thing, saving the patient. It's very, very nice to have that. And this is the institution that I'm in. Yeah.
Thank you, Dr. Najib. Now we have come to the end of all the 4 sessions, and over to the chairpersons and moderators for the discussions. We can have a 10 minutes discussion. So.
Thank you, Dr. Najib, for that brilliant exposition of when the thrombus dances in the heart, putting your life in trouble, how to, within minutes, how you can suck it out. Obviously, there will be questions from the audience. The topic is open to the audience for questions.
Questions to the obesity man. Right? Topromate is the same drug that you use for migraine. How frequently have you used it, and how many cases you encountered developing acute glaucoma? Because it's a very common thing. It can produce loss of vision.
So, topromate is a drug which has been widely used in the United States for multiple reasons. And I've seen topromate used by medicine a whole lot. I mean, glaucoma-wise, we do tell them about vision changes or headaches and persistent headaches or some symptoms, and they usually, I have not encountered myself any. But topromate, since you asked, it's very interesting that people who have soda addictions, like taking a lot of sodas, it actually changes the taste of soda. So when you are in topromate, people will come and tell soda tastes very bitter, bad. So one of the reasons which has been used is for that reason. So it's all the different things which is used for that. Yeah. Yes.
But I think, weight loss in obesity is a very difficult thing, Whatever that you do, counsel, it's very, very difficult to achieve more than 10% of the weight loss in 10% of the patients. So that is the roughly world over the figure. But now a lot of interest coming up in GLP-1 agonists, liraglutide and SEMA. And then again, we have got some experience of the off-label use of liraglutide and GLP-1, and non-diabetics, is found to be good.
Yeah.
So what is your long-term, do you have any long-term experience there, and do you have an FDA approval for that?
Yes. So there is an FDA approval for not liraglutide, semaglutide, and tripizide for obesity management. So it is there. Drugs are named differently. It comes, I cannot name the drugs, but So that's how we differentiate which is used for obesity or for diabetes. So basically both of them are metabolic diseases, and so one starts from metabolic obesity, metabolic disease to go to diabetes. So there is an overlap of it. So definitely these medications are really good, and it's been very rampantly used, very much marketed in the United States. It has become a big shortage there, and then what happened is that then a lot of small compounding pharmacies started making it, and they are much unregulated, and then it's been widely used. But the issue is, I have seen many patients come with, we have used this 20-pound weight loss, and then I cannot change. So you go from one to another one, and then what happens is that that's not working. So that's the type of resistance which is coming. So side effect of both these drugs are bad nausea, vomiting, and intolerance of these medications. Sorry, go ahead.
Question to Dr. Dheeraj. Do you do arthroplasty purely with a
1 minute.
block?
I request all the speakers to come over to the stage, please, to take the questions.
Do you do arthroplasty but just with a femoral block or something, without any?
Not the total knee we can do with a adductor canal block and a IPAC block, and we have to give an infusion of propofol or something to keep the patient asleep because they don't want to hear all the banging sounds and all that. But basically it is possible to do it. But what we generally do, nowadays the surgeons are, we used to do that a lot with MAC and blocks, but now the trend is towards putting a block preoperatively and then put an LMA, a light general anesthetic, because of the block, we have to use substantially low amounts of anesthetic. So it is a very light plane just to keep the patient asleep, and then as soon as the last stitch is on, we extubate. So it is very fast, and then we come to the PACU, the patient is wide awake, and patient can participate in therapy very early on. Yeah.
I think this can be given as a thesis for the postgraduates, madam.
Deepa, Dr. Deepa, you know that semaglutide only tablet is available in India. Semaglutide only tablet is available in India. Our only question is, people are using and nobody knows when to stop it. So how long you have to use it? Do you have any experience where you have to stop the treatment? We know that it is also, even without diabetes, it can be given in obesity, and it is FDA approved, not only for semaglutide, for the tirzepatide also.
Yes.
So we want to know, there is a doubt and more confusion. How long you have to use it? People are afraid to stop it.
Yeah. So any obesity is a metabolic disease which is not going to go away from you. It is going to be, if it is diabetes, is like you have to use the medication for lifelong. Obesity is something like that. It's the root cause of the diabetes in patients with that. So I have stopped semaglutide at a stage that it's kind of leveled off, the weight loss has leveled off, and patients are like, I will try it out. I've started eating well, I'm doing a lot of exercise. So you pick up the exercise part, the muscle strength is better, and so you have lesser insulin resistance. So we can try to stop it, and some people, there is no scientific data that they could stop it and start changing the behavioral pattern. But most of the patients are staying for, this drug has not been there for more than about 1.5 years to 2 years now, and nobody has literally stopped it. So to add to one, Dr. Dheeraj's, I use tab blocks so much in my surgeries, and patients actually literally come out and say, I don't have any pain. Did you do the surgery on these patients? And with the robotics and tab blocks, it has paradigm changed that we could actually do surgeries, sleeve gastrectomies, and send them home the same day home. So that's how much it has changed. I just want to.
So just a quick question for Najib. As a hematologist, we are quite interested in PE. I think it's a such a good response. The response after the thrombectomy is so nice. In our place, the interventional radiologist does the thrombectomies, not the cardiologist. So how come you got interested?
I detest that. The reason it's nothing like that. Radiologists can do it also. The most important thing I feel about radiology is that they hardly ever use pressure recordings. It's a big problem because especially you go with the large bore devices, you'll be sticking into the wall and other things. Your pressure is your true north. And not only that, you need to know what you're doing. We always measure the initial pressure and then see what the responses are, what good we did in functional aspect. All those things are very important. And we are used to going through. We took it away from radiology long back. We don't want to give it back to them.
Nice talk.
Najib, you have done a wonderful job. One question, whether the interventional radiologist does it or cardiologist does it, there is a difference between the two. Cardiologists are well versed with the hemodynamics of the heart.
Yeah, exactly.
And I have been working with interventional radiology also because training them was also a part of my work in cardiology in Trivandrum Medical College. So I know that there is no constant hemodynamic monitoring happening in interventional radiology. And here is a situation where the patient can slip off your hand while doing the procedure. You are going to do a thrombectomy procedure in a very sick patient.
Very sick patient.
Very, very sick patient where you don't have the guarantee that you are going to take him back live. So I think a good knowledge of cardiology is important for the interventional radiologist who does it. That is the point.
I completely agree. Otherwise, it should be a double call for us.
Nice talk, Najib, and with the excellent results. What is your take on IVC filter following this procedure? Do you use it nowadays?
Good question, sir. So, IVC filter only if the patient is contraindication for anticoagulation. So, IVC filters indicate only in that situation. If the patient has there are some certain situations with the bleeding issue, you go and do thrombectomy. You may give a little bit of heparin during the procedure and then get the clot out. And if the patient cannot be anticoagulated afterward, then you put IVC filter. But if the patient can be anticoagulated, no IVC filter.
Thank you.
It actually took million years for the human thrombotic system to evolve. Essentially, it involved to protect us from more bleeding to our violent encounters and during parturition in the forest. But as we become more obese and less mobile and as age advances, the clots form in the lungs and starts dancing in the heart. That's where the life becomes very critical, where Najib goes in and pulls out the lollipop in minutes.
Najib,
so we can filter it out when we can't give antibiotics.
Excellent talk, enjoyed your talk. My question is, in a center with facility, would interventional strategy become the default strategy rather than thrombolysis?
No, that's a very, very important question, sir. That's why the importance of the pulmonary embolism response team is. Nothing is out. That's why we come together in the middle of the night, talk about it. Unlike STEMI, especially in submassive, it's not that the patient need to go straight away to the cath lab. If it is massive and the hemodynamic compromise, then of course. Otherwise, you can watch and wait and see how the patient does. Many a time, sometimes even though the RV dilatation is there, the patient continues to improve very well, the size comes down, we may not do it actually. So the timing is actually, that's why I said it's a dynamic process and then you decide accordingly. Yeah. But the facility is there, then it is a very, very useful tool. Yeah.
Dr. Dheeraj, yeah, here.
Ramesh, time is quick question.
Yeah, just it's a nice talk on the blocks. I just wanted to tell you that our anesthesia team in Trivandrum Medical College is doing a great job. We use regularly tap blocks and the outcome is very good. I just wanted to put it on record here.
Yeah, thank you. Dheeraj, we are concluding the session, and Dheeraj, one last question about, because we do all the blocks and regional blocks and analgesic blocks, everything we do, but only point is that we don't have a drug of liposomal bupivacaine. What's your experience on that? Because liposomal bupivacaine gives around 48 to 72 hours of analgesia, extended analgesia, without affecting the motor blockade. What we do is that we use a dexamethasone it will get around 48 hours, but this muscle blockade is prolonged. Our concept is site-specific anesthesia and analgesia. So what's your take on that, your experience on that?
My experience is mostly the surgeons prefer to do the liposomal bupivacaine because anesthesiologists, we do the blocks and we prefer doing the blocks. because the liposome bupivacaine is mostly like a local infiltration done by the surgeon. So it is not targeted towards the comprehensive pain relief. But they have good results with it. It's very expensive.
Doing
That
it
is
IPAC and also with IPAC and with the liposomal, all good results.
Yeah, but you don't need that much prolonged anesthesia. But it is the expense factor is what limits it. You know.
Thank you.
Yeah.
Thank you. Thank you.
Can I add to this? So when we have a port site local anesthetic, we use liposomal, and it has gone away right now with the advent of good TAP blocks. So it is still used, usually by us on port sites mostly.
Yes. Thank you. Thank you to Madam to conclude the session.
Thank you so much. What an excellent presentation. And me being here as part of ATMG UK, I'm just the immediate past president. It's such a joy to be welcoming and also be part of the discussion of the AKMG group, who are so dear to us anyway. So brilliant. So Trivandrum and UK and US all meeting together. What a great forum. Thank you.
As we are coming to the end of the session, please wait. So I thank all of them, that is all the speakers, and especially Dr. Deepu Sudhakaran for organizing this wonderful session, which are more practicable and useful for, I think, most of the people sitting here in the audience, among the audience. And thank you all, and thank you the chairpersons and the moderators. Now, the next set for the award of the scrolls.
I invite the speakers to remain on the dais. I invite the chairpersons to present the scrolls to the speakers. Dr. Lynette ma'am, please present the scroll to Dr. Deepu Sudhakaran sir. I also invite Vinay Gopal sir, Suma ma'am, and also Lakshmi ma'am to join on the dais. Now, Dr. S. Shivashankaran sir to present the scroll to Anup sir. Dr. Elizabeth ma'am, please present the scroll to Dr. Dheeraj sir. Dr. Devika ma'am, please present the scroll to Dr. Nejit sir. I invite Vinay Gopal sir, Dr. Suma ma'am, Dr. Lakshmi ma'am to the stage for the group photograph.